If your loved one just came back from Iraq or Afghanistan and they say they were knocked out at some point, use that as a key to get them into a healthcare provider. The impairments that I mentioned, in particular the cognitive and the emotional behavioral impairments that you can have after mild traumatic brain injury can absolutely destroy lives. You can lose your job, you lose your spouse. They're devastating, and they can be long-term, so they need treatment. And really, the reintegration process and coming back, having that support as soon as you come back, and having it recognized what your problem is very important, so that you start off on the right foot.
Joining Forces, Gray Matters, is a co-production of Health Partners Institute for Medical Education, a nationally recognized provider of continuing education for health professionals, and TPT's Minnesota channel.
How does a physician know they're dealing with a member of the military? I have asked throughout Minnesota if clinicians in their offices would simply ask everybody, have you been in the military? Simple question. If so, when? And if they give a time period that equates this war, where did you serve? I served in Iraq, I served in Afghanistan. That should open up the ability then to say, were you ever in the proximity of explosions? How close? Were you ever fired upon? How close? And from that, we can begin to ask some questions to see if there was any lingering issues from those experiences.
Blast injury has been there in previous wars. You know, there's been terms such as shell shock and a number of other terms used to describe these changes people experienced after war. It's just that the mechanism or the weapon of choice wasn't the ID. And there are a few factors that make Iraq and Afghanistan different. Number one, as I mentioned, is the weapon of choice being explosive devices which expose service members to blasts. Number two would be that body armor and armament on vehicles has drastically improved since previous wars. So service members are surviving blasts or injuries that they never would have survived before as a result of this. Unfortunately, though the vital organs are protected, the brain inside the skull is still susceptible to injury and force being transmitted through them. And finally, military medicine has improved significantly as well. It could take as many as 2 weeks for someone who was injured in Vietnam to return to the continental United States, where in Iraq and Afghanistan, it's 24 to 72 hours that transfer can occur. So those three factors combined are leading us to see more severe disabling injuries that service members have survived, as well as multiple minor injuries that are causing long-term impairment.
They may not even know some of the issues that they're going to have, and that's really the whole thrust of our reintegration program. We are reevaluating them at 30 days, 60 days, and 90 days, and beyond, with face-to-face time with healthcare providers and counselors at each time, but particularly at the 90-day program, to ask them again about specific questions, to screen them for psychological issues, to screen them for traumatic brain injury, which is another one of our concerns. And so, in answer to your question, it's just evaluate, 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 and keep asking them the same questions.
And we work closely with the Veterans Administration, the Vet Center arm of the Veterans Administration, which provides readjustment counseling, which is a great tool for any clinician to know about, that every major city in the country and many, many rural areas have VA clinics that do nothing but counseling for combat veterans and their families.
During the summer of 2007, the headlines were full of news stories and reports about the 2,500 Minnesota National Guard members who were serving active tours of duty in Iraq. Returning soldiers have had an opportunity to reacquaint themselves with their new lives back home, but some questions remain. In past programs, this series has looked at the effects of wartime trauma as it relates to the family, communities, and the soldiers' mental and physical health. This episode will deal with traumatic brain injuries. how to recognize the progression of such an injury, how to treat them, and how to help a soldier cope. With us to answer these questions and further discuss the matter is Dr. Michael Armstrong, the Director of Outpatient Traumatic Brain Injury and Polytrauma at the Minneapolis VA Medical Center. Thank you for joining us. Good to see you.
Thank you.
Let's get our definitions down first. What is traumatic brain injury?
I think if we talk about it in simple terms, a traumatic brain injury is an injury to the brain. To have a traumatic brain injury, to have this insult or injury to the brain, we need an external force. So whether it's a blast or a motor vehicle accident or in a football game, two helmets colliding, that produces a diminished or altered mental state. From there, it produces various degrees of impairment in cognitive, emotional, behavioral, and physical functioning.
Give me an example of some of that continuum.
Some of the continuum in terms of symptoms would be physical symptoms, may be headaches, dizziness, vertigo symptoms, head spinning, changes in hearing, chronic pain complaints, changes in vision, sensitivity to light would be some physical impairment examples. Cognitive impairment examples may be problems with short-term memory or kind of day-to-day memory, where you put your wallet, what you were supposed to do today, when you were supposed to take your medication, or did I have an appointment today? Attention, can I read a newspaper all the way through without having to reread the same line over and over again? And just generalized efficiency in brain processing. So how quickly do you learn new things? If you're going back to school or you're changing jobs at work, how quickly can you make that adjustment? And finally, the emotional continuum or the emotional spectrum and behavioral spectrum is really what we see in a number of other conditions as well. Irritability, low frustration tolerance, a short fuse, so to speak, and also symptoms of anxiety, depression, and a number of other mental health diagnoses.
What's considered mild versus severe?
In the medical community, we like to divide things in thirds, and we haven't spared traumatic brain injury from that either. So we have mild, moderate, and severe brain injuries. My area of expertise is mild, and for the purposes of mild brain injury, it's just that, it's mild. And we have some specific definitions. Most importantly, to have a mild brain injury, you need to have this external force or an event that either causes an altered mental state, dazed, confused, saw stars, a loss of consciousness for a period of time that must be less than 30 minutes, or post-traumatic amnesia. And what I mean by that is forgetting the events either immediately before or after the event that you were injured in. And that can exceed 24 hours, cannot exceed 24 hours.
Is this different from a concussion?
The terms, for the most part, are synonymous.
Okay. You know, much has been written about traumatic brain injury in Afghanistan and Iraq. What's going on with these conflicts to cause the number of traumatic brain injuries that we're seeing?
There's a number of factors, and please stop me if I go too far with them. First of all, it's the mechanism of warfare, the weapon of choice in Iraq, which is the blast. It's improvised explosive devices, or IEDs, which anyone at this point has heard about in Iraq and Afghanistan. It's rocket-propelled grenades. It's really the weapon of choice. Secondly, there's no true front line in Iraq or Afghanistan. Everyone's susceptible, everyone's exposed. Another factor is the improvements in armor and body armor that we're seeing in Iraq and Afghanistan. Modern military has made vast improvements in this area. Now, vital organs are protected in a blast, say from shrapnel, but the body itself can be thrown or injured, and that force gets transmitted to the brain, much as you'd see in a car accident. But this is an invisible force as a result of a blast, forcing itself on the body. And finally, it's the improvements in military medical care. Since, just even since our Gulf conflicts, and now in Iraq and Afghanistan, the military medicine has improved vastly. It's far different than it was in, say, Vietnam, where in Vietnam it may take 2 weeks to get to the continental United States for additional care. It can be as short as 48 to 72 hours in Iraq and Afghanistan. Amazing. So soldiers are surviving injuries that they never would have before. And if you have the force that can force you to lose a limb or traumatically lose a limb, that force likely transmitted up to your head, and you may have had a brain injury as well.
I hate to be graphic here, but medically speaking, what does happen inside the head when there is trauma to the brain? What has to happen in order to have that injury occur?
The force itself has to occur. That's the primary event. So that force does not have to necessarily be a direct blow to the head, but can be what we call an acceleration or deceleration injury. The brain is tethered inside of your head, but it floats freely within your skull. So a sudden stop or a sudden acceleration, as you might feel when getting knocked back from a blast, can actually shake the brain inside the skull and cause bruising or a contusion inside the skull. So that is directly there, a mechanism of how injury can occur without having a penetrating injury such as a gunshot wound or a shrapnel injury that actually penetrates the skull.
Is it relatively easy for a physician to pinpoint that injury, say with an MRI?
Well, we have to be clear. In terms of moderate and severe, yes. Those realms of injury, imaging does help. In mild brain injury, only about 10% of individuals will show findings on imaging at the time of the injury. And that's important because by the time most providers will see them when they return to the U.S., those findings will have resolved, and we will likely not see any long-term findings on imaging. So there's not one clear diagnostic approach other than good clinical training and clinical experience to approach this problem.
What is your best advice then for physicians when they are dealing with a potential, when they think they might be dealing with somebody with TBI? How do you go through the steps to try to diagnose?
I think first is to pick a standard of diagnosis. At the VA, or the VA healthcare system, we use the American Congress Rehabilitation Medicine Standard from 1993. And that lays out specific criteria. Again, an external force that's transmitted to the brain that results in either a loss of consciousness, again, less than 30 minutes, post-traumatic amnesia, less than 24 hours, or really any altered state of consciousness. So if you're seeing stars or you're dazed or confused, those symptoms right there are enough to say you've had a concussion. Now what's important to consider is that the symptoms of concussion are common in everyday individuals. So we have to be careful not to really express causality or that the reason their symptoms are there are mild traumatic brain injury. It certainly could be, but we need to look for a number of other conditions that could mimic or have the same symptom presentation as mild traumatic brain injury.
If someone is diagnosed with mild traumatic brain injury, how is it treated?
Good question. There's a number of approaches, all of which have been proved beneficial. Education alone is enough to show benefit in persons with mild traumatic brain injury for long-term improvement. We use an interdisciplinary rehabilitation setting in the treatment of traumatic brain injury, which is really guided medically at just reducing suffering while we expect recovery and compensating for the problems they have. So, for example, you have headaches and we expect some recovery, or we expect you to continue to recovery from your concussion. We'll treat your headaches. We'll treat your sleep problems in the meantime to eliminate those factors and allow normal recovery to occur. I may send you to an occupational or speech therapist. They may provide you with a Palm Pilot or a day planner to organize your life to help with those memory tasks I mentioned that might be more difficult to remember at this point. So those are some of the treatment aspects we use. Additionally, in terms of diagnostics, we can use neuropsychological testing to help get some objective data in what areas someone is having more difficulty in. So if it's primarily in attention, we may use a medication to help with enhancing attention, such as the medications that are used in ADD. So there's a number of individual treatment approaches. I would just say for most providers, know what your resources are and refer when you feel they're outside your scope of practice.
What's the recovery process like? I presume it must be different for everybody, depending upon severity of the injury.
It is, but recovery is the norm. When we look at the spectrum of mild traumatic brain injury, within the first 3 months or so, about 80% of people will have symptoms. Within the first day to days, most people will recover. In fact, by 3 to 6 months, 80% of those 80% will have recovered. By a year, we expect somewhere around 95% to have complete recovery from mild traumatic brain injury. Now, there are a small number of people who will have symptoms beyond that, and estimates have ranged from 5 to 15%. But we start looking at other factors. We need to consider what other factors are at play. Is this truly a neurologic abnormality, or is this truly some unsuccessful coping, poor social structure, changes in the individual's life since the trauma that are really kind of perpetuating the difficulties they're having? So we need to be careful in labeling symptoms as directly a cause for, or being directly caused from traumatic brain injury, and really look at all the other possible conditions.
Interesting to note that the recovery rate is high, because I think some people wonder, if you have a traumatic brain injury, are you forever changed?
No, sometimes having trauma can forever change you. Sometimes having mild traumatic brain injury can change you forever, but it's not the norm. I would mention that a single event, like a high school football player having a concussion on the field, is not the same as being in combat. These are very different situations. So when I talk about recovery patterns, I talk about them in terms of civilian literature. What's been studied here in the U.S. in civilian literature. And there's plenty of opportunity, because there's 1.5 million mild traumatic brain injuries a year in the United States alone. So when we talk about combat, one injury is not the norm. Multiple injuries are the norm. So cumulative concussion or cumulative mild traumatic brain injury may change that recovery pattern. We still need to do that research. The jury's not back yet on whether or not this cumulative injury is causing more problems. Also, I've had individuals who've had 50+ blast exposures. Maybe only 2 or 3 actually caused a concussion. But what do all those additional blast exposures do to an individual who's in combat? We still don't know that information yet either, and we continue to work towards finding out how these situations impact our patients.
Do you have any advice, doctor, for families or employers who have someone dealing with this situation?
I do, and that is, first, that recovery is the norm, so we hope that people get better. And oftentimes patience and understanding is the best thing, and support is the best thing family and employers can provide in this setting. And know when to ask and when to look for help. If your loved one just came back from Iraq or Afghanistan and they say they were knocked out at some point, use that as a key to get them into a healthcare provider. Most people don't want to spend 12 to 18 months overseas and come back and then spend 2 weeks at a hospital being treated or having appointments every day. They have families and lives to return to. And so we need that partner. We need the family to partner with us to help identify these individuals so we can help them along the way.
Can you see where traumatic brain injury might hinder, to a certain degree, reintegration?
Absolutely. The impairments that I mentioned, in particular the cognitive and the emotional behavioral impairments that you can have after mild traumatic brain injury can absolutely destroy lives. You can lose your job, you lose your spouse. They're devastating, and they can be long-term, so they need treatment. And really, the reintegration process and coming back, having that support as soon as you come back, and having it recognized what your problem is very important, so that you start off on the right foot.
You mentioned, I think the figure was, if I heard you correctly, 1.5 million people with traumatic brain injury in the United States. That's civilian?
Civilian per year.
Okay. So at this point, what do you know about figures from Iraq and Afghanistan? And I ask that question because community physicians will be seeing these folks, as we talked about briefly.
Community physicians will be seeing these folks. They won't see the more severe cases. And even the mild cases, the VA and military healthcare systems have prepared. They may never present. They may not come to the VA or medical or military medical systems for care. In our own screening of those deployed to Iraq and Afghanistan, 8 to 20% are screening positive for symptoms related to their concussion. So with that rate and over 1 million who've served, you can see that the numbers are very large, and that they may present to a primary care provider, and no one may have addressed this before. So we certainly want private sector physicians to really be asking the question, were you deployed to Iraq or Afghanistan? When you were deployed, were you exposed to a blast? Did you have a loss of consciousness? And know their resources, and have a relationship with VA and the military, so that if they don't have the resources, they refer to us for additional support.
I was just going to ask you how the civilian medical community can be helpful in this respect? I think you probably just answered that in terms of partnering up. That seems to be important.
This is a team effort, and it's a team not just made of military and VA providers, but also the private sector. We simply cannot reach the number of individuals just who don't want to come to the VA or military. We've done outreach efforts with the National Guard. We've done outreach efforts with private sectors to really kind of raise the alarm, say, be looking for this, refer to us, and really get the word out there. But we need that help. We need that help.
I know that you've been actively working and doing research on this issue. Have you heard from private physicians, healthcare clinics, hospitals about what they're seeing, and are they funneling patients back to you? Do you have a dialogue going here?
We have a dialogue when we have referral, and a number of my patients have been referred directly from private care. We do have ongoing relationship with private care. This is an example of that alone. So it's a regular experience for us. It's part of how we practice, and really, at least in Minnesota, this healthcare continuum is private, VA, and military altogether.
Before you go, this is obviously open for research. What are researchers really looking at when it comes to traumatic brain injury? What do you think you might find as you start looking at numbers coming back from overseas, soldiers coming back home from overseas? What are you going to be really looking for when it comes to the body of research on this issue?
You know, one of the things we've seen is that mild traumatic brain injury is rarely an independent finding. That is, if they're having symptoms, there's typically adjustment disorder, combat stress, post-traumatic stress disorder, and a number of other conditions that are playing a role. So we need to do a better job in this dual diagnosis or two diagnosis of trying to delineate which one is the greatest, or if we need to delineate which one's the greatest, and treat as is. I guess the other area I would look at is cumulative blast exposure. What does this mean? And I mentioned earlier, what does it mean to have multiple concussions in the combat setting, and what does it mean to have a concussion but multiple exposures to other blasts that aren't significant enough to cause a brain injury?
What else do you want to add about this issue?
I would just say I would like providers or family members to first identify who's been there, and then ask the questions. Ask whether they were knocked out. Ask whether they suffered a combat-related injury, and then to know your resources and refer on. Help is available. We are screening every individual who touches the VA system, but for those who don't touch the VA or military system, we need that referral. We need that identification. We need these patients to get help.
Good work. Thank you, Doctor.
Thank you.
Well, that's all we have time for, this look at traumatic brain injury. Interesting conversation. Thank you to our guest, Dr. Michael Armstrong. I'm Kathy Wurzer, and thank you for watching.
As the research emerges, there seems to be gradation in this injury, and there seems to be other issues that are associated with it. And I'm only familiar with the short-term memory loss that I've seen personally in soldiers and experienced in working with them. I've seen some wide mood swings in soldiers. I've seen some distinct personality change. And the thing that's amazed me most in almost every soldier that I've dealt with that has TBI, and now I'm up into my hundreds of soldiers, a profound lack of self-awareness early on that this was a problem. And that it had to be reported to them by other people, generally family members. They had a sense something wasn't right. They chalked it up to the war, but they couldn't see it playing out in their daily activities. They couldn't see the memory loss, and I'm not sure why. They couldn't see the personality change. They always had the war to say, this is something about the war has made me angry. I can't concentrate because I'm just coming out of combat. They weren't able to say, hey, I've been profoundly changed. Most of those people that I've dealt with that weren't able to see that were in some sort of an explosive event where they walked away without a scratch. And that gave them an illusion they were okay.
Get up! Get up! Get up! You okay? You okay?
Let me see. Fine, not a scratch on them.
Now we're changing that quickly on the battlefield, screening people almost immediately after they're in any sort of concussive explosion. And so we're raising that issue, training all of our soldiers now to look for the signs of TBI. So we're normalizing this injury in the Army and educating people, and I think that those two are going to break through some of that lack of self-awareness. But maybe that self-awareness comes out of the injury itself. I don't know. I don't know. But we see it on the battlefield. We're screening for it now for every soldier that leaves Iraq and Afghanistan, and the VA is scrambling hard to garner the resources to address this emerging problem.
Whereas it's true that only 5% of the population is involved in the military, the truth is that we are still talking in hundreds of thousands of soldiers now that have been involved in this war. And so anybody that thinks they don't know or don't have one of those soldiers in their practice simply is not aware. We're talking about large numbers of folks and their families who are equally involved in this. So I think if a physician believes that this does not affect them, they may want to look at that a little bit more closely.
Joining Forces, Gray Matters is a co-production of Health Partners Institute for Medical Education, a nationally recognized provider of continuing education for health professionals, and TPT's Minnesota channel.